Good morning, everyone, and thank you for the opportunity to be here to speak to y'all, and thank you to the National Academy of Sciences for bringing together this workshop on such an important topic. My name is Mark Ryan, and I'm one of the family medicine physicians and faculty at Virginia Commonwealth University. And although I'm here speaking on my own behalf, I think my experiences through my training, through my practice, and the current work I'm engaged in teaching medical students and working in primary care reflects that of many of my colleagues and peers across the United States. I don't have any slides, but I wanted to instead share some of the context and experience on the front lines in primary care and why this conversation is so very important on a daily basis for the work that we do, and why it's going to be so important to train our learners and our medical students and our residents how in better ways to engage in chronic pain management and chronic pain care. A little bit of context: I graduated medical school in 2000 and finished my family medicine residency in 2003. I really frankly don't remember much education at all about chronic pain or pain management in my undergraduate medical education. Through my M1, M2 years, we had some pharmacology. We talked about pain medications, method of action in my third and fourth year. It depended a little bit on where I was rotating as to whether it was part of the conversation, but there was really no formal or discrete curriculum I can recall. When I moved into residency, that's around the same time that the conversation nationally on pain management began to shift. Pain became the fifth vital sign, and pain became something that needed to be addressed and assessed every visit, and done so in a way that would show outcomes that were beneficial. But we were challenged because the way that those outcomes were being measured in many cases was through the 1 to 10 pain scale we heard about, and not through global function or quality of life or other metrics. But in residency, this became something we were expected to do, and it was a requirement of the kind of work we were engaged in. And at the same time, we were being told through information that we now know was at least disingenuous or misrepresented, if not dishonest, that opioids are safe, and that if you have real pain, you will not become addicted to opioids. And you can escalate the dose until patients respond and tell you that they are doing better. I remember one of the definitions that I was trained with, roughly to paraphrase, was pain is a noxious or uncomfortable sensation of the patient's description occurring as the patient reports it and improved as the patient describes it, which then leaves, as the practitioner, a significant gap in measurement and understanding and really assessing the effectiveness and potential harm of the medications we were using. And it was all medications. The idea of integrated care and comprehensive integrated behavioral health and physical therapy as part of a team was not part of my training. When I went into practice in rural Virginia in 2003, I worked there for 4 years. We had no pain management specialist of any kind for at least 1.5 or 2 hours driving. That was if you could find someone who would take your insurance, and if you could find a patient who could drive from rural Virginia on a regular basis. We had no local resources for pain management. Our local orthopedic folks were not particularly focused on that aspect of care. We had no other pain management service, and we had very limited non-pharmacology options. We had a physical therapy office in town, which was pretty good for orthopedic work and other rehab, but this was not their particular source of expertise or area of expertise, and they did not do some of the more advanced pain education, for example, that patients can benefit from. When I moved to Richmond in 2007, to where I'm working now still, 40% of our adult patients at Hazy Willis are uninsured, and they are covered by the healthcare system's indigent care plan. Many of those folks are not working, in many cases related to other medical comorbidities, and chronic pain as one of their major concerns. And because they were not qualified officially for disability, their conditions were not such that they were disabled, many of them were coming to our services. And with that influx of patients looking for assistance, we have had no pain management clinic in our academic center until the last 2 or 3 years, when one finally has come back online. We had limited options for non-pharmacologic management. Also, we could make referrals to physical therapy or for other assistance, but the scope of the services provided, and equally importantly, the patient's access, practical access, getting on a bus, taking the day off your job or whatever needed to be done to get down there on a regular, consistent basis, made that very limited. And outside the system, our pain management in Richmond at the time was very limited in terms of insurances they would accept. So if you were uninsured, of course, you had no real options. If you had insurance, it depended on which program. and most of the pain management specialists we were working with were proceduralists who were really looking for nerve blocks or epidural injections or things of that sort. There was no real integrated pain service that we could refer out to. And some of the things that I think we're going to hear about in the next few days, integrative approaches to care, acupuncture or other services, how physical therapy can be made more effective than eval and RX. None of that was really part of the conversation, and our patients, even if we could make those referrals, wouldn't reliably have access to that. So what we ran into is the high number of patients with chronic pain, many of them coming to us after many years of reported symptoms, which then led to a series of challenging interactions. Patients who wanted to feel better and physicians who did not know really how to do that other than opioids and were uncomfortable providing opioids or did so under some duress. We had this characteristic pattern of anytime a new provider came on board, we would get a bunch of new patients scheduled with that provider, all of whom were asking for pain management services. There was this kind of testing of the new provider to see if you were the person who would make that prescription. And all this, of course, led to dissatisfied, unhappy, and unhappy patients dealing with significant concerns, and unhappy and dissatisfied providers who would look at their schedule and sort of have their hearts sink at the roster of patients coming in today who were going to be asking for, expecting, or in some cases, genuinely demanding that we do something to improve their pain. We've also experienced limited patient understanding of and willingness to try non-opioid and non-pharmacologic treatments. Sometimes they just don't think it's going to work. Sometimes they've tried it once, years before, and have no desire to try it again. We have lacked a comprehensive and integrated pain management approach, again, until recently. Integrated physical therapy, behavioral health into the team in a more intentional manner has not been part of our standard practice. And then managing chronic pain in a medical system or a healthcare system more broadly that looks at RVU and productivity, where time is an issue, where you're expected to see a certain number of patients a day, while also caring for all of these patients' other primary care needs. It's rare that I have a patient who's coming to see me for chronic pain management who also is not coming to see me for their diabetes and their hypertension and their stress or anxiety or other medical issues, all of which are my responsibility. That's led to this crisis then. In light also with this new data on the risk and harm of opioid treatments and the better understanding of how this had been represented or misrepresented over the years, as I've been watching some of the evidence-based medicine newsletters, some of the medicines that we oftentimes use in primary care as perhaps thought to be an easier, safer alternative to opioids like gabapentin or pregabalin, some of those medications, the evidence for treating some of the pain conditions for which we're prescribing them is really not strong. We've been prescribing these options, but we don't have great evidence of what we should be doing instead. We are really facing this challenge in the context of patients who have very long-standing symptoms, very significant impacts on quality of life and function. So it's not that it's a problem that we can just not pay attention to. And then, at least speaking for myself, with my career path, this sense of some complicity in how my patients who I've worked with over the years who ended up on opioid treatments are now on some cases on high-dose treatments. And I don't know that I'm ever going to get those patients opioid-free. And how to provide better care for those patients who are already in that mode of care, but more importantly, equally importantly, heading forward, how to avoid getting people into that higher risk position in the future. So what I'm hoping for from primary care from this conference is that we find ways to provide actionable and practical strategies to address primary care in the primary care settings, using approaches that can be really widely disseminated but also implemented outside of an academic practice, to outline evidence-based and effective approaches for caring for patients with chronic pain that are not reliant on opioids or even necessarily on other medications, to provide provider and patient communications, to improve provider and patient communication regarding treatments and goals for care and chronic pain, and to provide for collaborative and holistic approaches to chronic pain treatment in a model that encourages shared decision-making, and to encourage research focused on improving chronic pain management in the primary care office, where much chronic pain care currently takes place. And with the workforce concerns we heard earlier, this will remain one of the frontline points of contact for chronic pain management in the future. And I think that we need to move all of this with the goal of moving beyond what now feels like a risk-based, legalistic, and potentially antagonistic approach to care, where my job as a physician is to check your PMP, see if I can catch you with a dirty urine that doesn't belong there. I mean, it feels like the kind of work I did not go into medical school for. We need to focus on wellness, function, quality of life, with the goal of improving both patients' and providers' experiences. So thank you for the opportunity.